Der Instagram was live übertragen oder nicht?
Das geht nicht. Ich habe gerade über Instagram nochmal.
Hello, hello. My name is Emma Cloney, and I am here on behalf of Lipedema Canada. I do apologize for the late start today. We, of course, had some technical issues related to being in two very far apart time zones from our German doctors who are joining us today. So thank you again for being patient with us. I think we've got our tech issues sorted out. For those of you joining us live from the YouTube stream, please just be aware that when we get to the Q&A portion, we'll be taking your comments directly out of the comments that are there on YouTube. So if you look up to what for most of you should be the upper right-hand side of the screen, you'll be able to see that there is an opportunity to add your comments and questions there, and we'll try to get to them at the end of the live stream. So I'm here on behalf of Lipedema Canada, which, in case you didn't know, is the official association and organization for lipedema in Canada, the one and only. We represent patients, and we work towards trying to really honestly get services that are here for lipedema from both the government, the community, and helping our clinicians learn more about a faceted approach. And surgery is only one component of a whole person holistic approach to treating lipedema. We are hosting this for no financial benefit, but simply for information, because lipedema surgery and lipedema diagnosis and questions are a really big topic for a lot of us here in Canada and around the world. And getting access to clinicians who are as knowledgeable as Dr. Ghods and his team is rare. So we have a real treat for you today. I'm going to just give a little intro into who we're going to be meeting with, but not before I thank our sponsors for making it possible for us to even exist in this plane. So thank you to the Lipedema Canada sponsors, primarily our platinum sponsor, Bauerfeind. We will be bringing Dr. Ghods and his team in, and that's a name that you might have heard go around in the groups a fair bit. And the reason why is because Dr. Ghods and his team in Germany, they have been practitioners in lipedema for over 20 years. He has an entire team that works with him, and their practice is dedicated to lipedema. At the forefront of research, and one of the only doctors that we know of that also holds a PhD, as well as a doctorate. He is a chief in plastic surgery in not one, not two, but 3 areas, and one of those is in lipedema. I'm going to let him tell you more about his life accomplishments, and more importantly, about what he can do and help us to understand better about our disease. So without further ado, I am going to introduce our team of doctors. Look at this. Hi, guys.
Hello, hello.
Dr. Ghods.
Thank you very much. My name is Dr. Mojtaba Ghods. I am head of Department of Plastic Surgery in Potsdam and Bad Belzig. I have over 20 years of experience working with lipedema patients, and I would like to share my knowledge, my experience with you tonight. Before we started with a short presentation, I would like to introduce my colleague, Dr. Giw Mostofizadeh, please.
Hi, my name is Giw Mostofizadeh. I'm also one of the doctors working on the team of Dr. Ghods, and we'll have the pleasure of going through a lecture today together.
Dr. Amir Schweiz.
My name is Amir Schweiz. I'm also one of the doctors in Dr. Ghods' team, and also responsible for international patient communication, as one with Dr. Giw.
And my assistant, Barbara Werner.
Hi, I'm Katharina Werner. I am the manager of the international office of Dr. Ghods. I take care of the emails and the organization and the surgery.
Wonderful.
Okay.
Thank you guys so much. I wasn't expecting to have such a wide lens of the practitioners today, but this is a real treat. So what we'll do then is we're going to go in and do the presentation. So Dr. Giw, you said you have slides for us to sort of answer some of the questions that would come up naturally. And I'm going to turn it over to you and get those slides up and let you go ahead with that. We're getting some feedback. I'm going to turn up the volume on the doctors in the live stream as well, and we'll see if we can get that going. All right, so Dr. Giw, you've got your slides all ready there?
Yes, I'm ready.
All right, the floor is yours.
Wonderful. So basically, I'm going to take us through our surgical concept and the entire treatment process that Dr. Ghods has refined over the last 15 to 20 years. As we know, lipedema is a very complex and difficult to treat disease, and it is important to have an interdisciplinary and multimodal approach to it. So without further ado, let us go through the lecture. So as you can see, we mainly treat our patients in an inpatient setting and perform surgeries under general anesthesia. This is because we have the availability of a public hospital in which Dr. Ghods is the head of department. And for us, it's important to ensure the safety of our patients. So it is always a good idea when treating patients with large volume liposuctions, which this lecture is going to be about, to have an adequate aftercare. And for us, it's important to look after our patients for a prolonged period of time. So let me see. There we go. We have no conflicts of interest to disclose. What is lipedema? So lipedema is a painful, I'm pretty sure I don't have to tell all of you, but it's a painful disproportionate symmetrical fat distribution disorder of the extremities that occurs almost exclusively in women. There's very rare cases where men are also affected by it, but in those patients, usually there is some kind of hormonal imbalance as well in their patient history. The symptoms include pressure and touch sensitivity, spontaneous pain, and the feeling of heaviness. This is the definition that is given in the German guidelines, which have been published approximately a year ago. And Dr. Ghods is the head of the working group for lipedema of the German Society of Plastic Surgery. So he was directly involved in the development of these guidelines. Lipedema is not a new phenomenon. It's something that has been pictured since 1500 before Christ, as you can see on this Egyptian wall art. And it has been first published in 1951 by Allen and Hines, where they noticed this disproportionate distribution of fat. But for a long time after this publication, no one was really interested in the disease until at some point it re-emerged, and a lot of particularly German healthcare professionals started to find interest in it. We know the clinical symptoms. The question is, why do we operate these patients? Of course, there is the possibility of treating with conservative treatment measures to keep the disease in check, to prevent progression, but that's not always possible, right? We operate these patients because the disease is usually of progressive nature. It doesn't have to be a quick progression, however, it can be. And this in turn will lead to further complications down the road, starting from having these lobular deformations that will predispose patients to developing infections in the skin folds, to secondary lymphedema, which will accompany patients for life. The patient on the right is only 35 years old. What is the goal of the surgical treatment? It's a circumferential fat tissue reduction. With that, a pain symptom reduction, improved mobility, and an improved quality of life. these are the consequences, not always, but this is a very extreme case. But progression can lead to a point where your mobility is severely impaired. This patient has secondary lymphedema, of course, also an accompanying obesity, but the main problem is definitely the lipedema and lymphedema that she has developed with time. How do we select the patients is the question, right? When we are in Germany, the diagnosis is typically made by experienced lymphologists, and we go by the 4I principle, meaning that two separate, independent from each other physicians are required in making the diagnosis. I know that abroad it's not always possible. So for our international patients, it's always a possibility for us to confirm the diagnosis in case that most patients already suspect the diagnosis but have no healthcare professional to confirm it for them, and that's something that we can definitely do. But in Germany, we always receive our diagnoses from other clinicians who are not surgically active. Preoperatively, ideally 3 to 6 months of CPD, so complex physical decongestion therapy, is recommended in Germany. That's also for reasons of insurance coverage. CPD, for people wondering, is more or less wearing of compression garments and having regular MLD sessions. Then the diagnosis will be confirmed by us, and the indication to surgery will be made. And what is important to know is that in cases where there is obesity or strong obesity and extensive varicosis, it makes sense to treat these comorbidities prior to treating lipedema, right? What many patients ask us is, do you have a cutoff BMI? Is there a weight which should not be exceeded? Is there a BMI which should not be exceeded to allow me to come for surgery? It's always a case-to-case decision, right? The BMI is not the optimal measure for lipedema patients, as it goes without saying that with increasing fat tissue depositions, of course, the body weight will increase as well. That doesn't necessarily have to reflect, because the BMI is a measure of obesity at the end of the day, right? And with obesity come certain health risks. That is not always the case with lipedema patients. What has emerged as being a more relevant measurement is the waist to height ratio to show the disproportion. However, many patients have lipedema with an accompanying diagnosis of obesity. So they're not mutually exclusive, they can coexist. It's only important to identify and treat them according to the guidelines. How do we prepare patients for surgery? That's an important question, because the surgery is just a small part of the therapy. The preparation and the aftercare is what counts just as much. And as already said, if there's any prominent vascular diseases, you can see on the right-hand side that there's extreme varicosis. That, of course, is not the best predisposing factor for having surgery. So it makes sense to have these extensive varicose veins treated prior. Most patients will have some degree of venous insufficiency or some varices. That's not always a problem, right? It's very in these very progressed cases where it makes sense to have them treated. It is important to have a blood test prior to surgery or in the weeks leading up to surgery. Why? Because we will be removing a lot of tissue from the body. And with that, patients will lose some blood and patients will lose some fluids. And it is important to have a hemoglobin value. So hemoglobin is what transports the oxygen for you in your blood, and it's what makes blood red. It is important to be on the higher edge of the reference range because we expect a certain drop in hemoglobin levels from having surgery. It is important to check the iron stores because iron is the main element required for the body to build hemoglobin. Vitamin deficiencies, for example, vitamin B6, folic acid, or vitamin B12, because these are also essential in producing blood cells. Even more important in patients who have had bariatric surgery because a lot of these patients will have malabsorption of these vitamins or elements. We don't recommend our patients dieting rigorously preoperatively. It makes more sense to try and maintain your weight, right? Of course, if you are living a healthy, balanced lifestyle and are losing weight with it, that's perfectly fine. The goal is not to rigorously diet and starve yourself for surgery because it's usually associated with a yo-yo effect, so a rebound. If you're able to maintain your weight, it is easier and better post-operatively to maintain your weight. What we recommend is to increase the frequency of manual lymphatic drainage and wearing of compression garments in the weeks leading up to surgery. In patients who have an edematous component, it makes sense to minimize any edema present. And it also prepares patients or makes them get used to wearing the garments because it's important to wear the compression garments for 6 weeks post-operatively. It's a good idea to intensify movement exercise, do some aerobic training, trying to get cardiovascular health improved. In case of psychological comorbidities, depression is a very common comorbidity of lipedema, and it's important to be in a good place to have, if patients take medication, that they're set in a good way, that they feel comfortable, because it's important for the post-operative compliance, right? And it is not an easy journey to go through. The recovery can be quite tough, and therefore it is important to be ready and prepared for the journey you're going to go through. Many patients will ask, do I need a different compression garment for surgery? And typically the answer is no. We will usually fit the next compression garments earliest 6 weeks after surgery because as perhaps some of you have already gone through the surgery know, there is some substantial post-operative swelling that will make the compression garment that was fitting tightly prior will still fit quite tight. And once the post-operative swelling starts to regress, it makes sense to adjust a new one. So, coming to the surgical technique. As we already touched upon, our surgeries take place in general anesthesia with a short inpatient stay with large volume liposuction as the treatment method. And a short inpatient stay for our international patients will usually mean 7 days. There is no post-operative antibiotics as the rule. In some cases, it may make sense if the risk of infection is high, but usually patients will only receive a single shot antibiotic perioperatively on the operating table. We plan the incisions, we place the incisions, and then the liposuction commences either with a power-assisted device or with a water jet-assisted device, depending on the case. There's different cannula diameters that are used during surgery, depending on the layer of subcutaneous fat that you're in. The deeper the tissue, usually the larger the diameter, and the more superficial you go, the thinner the cannula, because thicker cannulas cause more skin texture irregularities. We suture our incisions to lower infection risk, to give an improved cosmetic result, and for patients who've had surgery with the incisions being left open, it can be quite messy. There's, and especially if you plan on traveling, all the serous fluid that is produced by the wound will sometimes cause issues on the journey. Intraoperatively, it is very important to regulate the body temperature of our patients, because the lower the body temperature drops during surgery, the higher the bleeding risk. So patients will receive heated IV infusions. There is an inflatable heated blanket that patients will be covered with in the areas that they're not being operated on, and the tumescent solution that is infiltrated into the tissues is also heated to 40 degrees. At the end of the surgery, there is some mechanical tissue modeling or lymphatic drainage taking place to evacuate all the excessive fluid and to model the tissue. Another important question is, in which order do we treat the patients? Because we can't treat the entire extremity in a single surgery, usually. It's very rare. And that's because volume doesn't always allow. For liposuction to be safe, it is, I think, collectively accepted that around 8 to 10% of the current body weight in liters, or in kilograms in liters, is acceptable for removal during a single surgery. And if you exceed that, usually patients will have a much tougher recovery with postoperative anemia and feeling of weakness, dizziness, and you will not be able to effectively treat the entire circumference of the legs in a single surgery. So it makes sense to split those. And there's different approaches. Some colleagues will do uppers and lowers, some will do inners and outers. And what Dr. Ghods has decided to do for a long time now is treating the anterior side of the legs as a first step, and then continue with the posterior aspect, because at the end of the day, it's important to treat the legs circumferentially. Treating uppers and lowers will give you a large difference in volume for both surgeries. So the anterior side is what we start with, because it's usually the area that bears the most symptoms. It's what causes the most problems, the knee area particularly. And then after 3 months of recuperation time, we can address the backsides. And then in patients who require it or who have symptoms in the arms, we'll treat the arms, or corrective surgery of areas that potentially need some improvement. And then further down the road, because we're removing a lot of volume from the tissue, one has to think about skin removal or lifting surgeries, because the probability of developing saggy or excessive skin is definitely there. And with some patients, the retraction will be satisfactory, and with some patients, it will not be enough. It's more on the cosmetic side of things. So it's something that every patient has to decide for themselves. In some cases, when the skin excess is very prominent, it may predispose patients to developing infections in the skin folds. In those cases, it would be indicated to perform a thigh or brachioplasty. How much do we remove? As already said, the target value is 8 to 10% of your total body weight. And of course, we have to adapt depending on how bloody it is. Patients who come from and have been treated somewhere else before, or need revision liposuction in an area that has been treated before, will typically be a bit more on the bloody side, because scar tissue tends to bleed a bit more. And of course, in those patients, we'll have to reduce the target value a bit to not compromise your safety. Many patients will ask, which device do you use? We have both devices. We have power-assisted and water jet-assisted liposuction. There is no randomized controlled comparative trials between both of those in regards to mega liposuctions. From experience, they give similar results. It's really the surgeon's preference. It's a case-to-case decision at the end of the day. Many patients will ask you, do you have laser or radio frequency devices? We don't use that because we don't know their safety in lipedema. Lipedema patients already have a lymphatic system which is working at max, and going through the tissue with a device that has high temperatures could potentially damage those already hard-working lymphatic vessels and lead to secondary lymphedema down the road. So until there's no data in that regard, we will abstain from using them for now. How do we treat the tissue? We, as I already touched upon, will treat the deeper subfascial because you have the skin, you have the superficial fascia, and then you have the muscle fascia. Below the superficial fascia, we'll use the 5mm cannula to get as much fat as possible. More superficially, above the superficial fascia, we'll use the 4mm cannula. And directly subcutaneously, as you can see in the photo, Dr. Ghods uses the 3mm cannula to promote skin retraction by stimulating collagen synthesis by going very, very superficially with the cannula. So one of the most important steps prior to having surgery is the preoperative markings. It is a step which allows the patients to communicate their areas of special interest or the area that causes the most symptoms. You can see that the markings take place in an axial or longitudinal direction. The reason for that is because mainly or almost exclusively the movements, the liposuction movements will be made in that longitudinal direction to spare lymphatic vessels and prohibit any damage to them, right? Areas that are particularly important for us, for patients, are the knee area and the ankle area, as well as the inner thighs, because they tend to cause friction. Then we place the incisions while the patient is on the operating table. The incisions have to be placed in a manner that allow us to reach all the marked areas without performing these transverse or crisscross movements. Then the incisions are placed with a 11 knife, and we can commence tissue infiltration. Tissue infiltration is an essential step in lipedema or liposuction in general, because long time ago, liposuction was performed in a dry manner, meaning without tissue infiltration. And a lot of these patients would bleed out because it is very aggressive. So tumescence solution is a solution that consists of saline and what we use adrenaline to, first of all, fill up the tissue, elevate all the layers of fat, and the adrenaline will cause vasoconstriction of all the capillaries and vessels to prohibit any bleeding during surgery. Colleagues who perform these surgeries in local anesthesia will have tumescence solution consisting of saline and adrenaline with local anesthesia. We don't need that because we perform them under general. Then we have the power-assisted liposuction device. The power-assisted liposuction device is a device which causes very fast back and forth movements or vibrational movements at the end of the day, which will break down the fat rather efficiently. And you can see the yellow fat going down the tube into the collector. And this is the water jet assisted liposuction, which, as the name suggests, shoots a rather strong water jet from the tip of the cannula, and in that manner loosens up the fat and breaks it down for easy removal. The fluid which is being sprayed out of the water jet device is the same tumescent solution that is used for infiltration in the power-assisted liposuction approach. So we've talked about the fact that our target value for a single liposuction is around 8 to 10% of the patient's body weight. And then we have to ask ourselves, how do we know we have removed enough from a specific area? And that's where the so-called pinch test comes into play. As the name pinch test suggests, you basically pinch the tissue and see how much space is left between the fingers. With most patients before surgery, this pinch test will be over 6 centimeters. It is very difficult to pinch small amounts of skin. With surgery, the goal is to achieve a pinch test of under 2 centimeters. It allows us to check for symmetry at the end of surgery to see if all the areas have had sufficient fat removed. And then adjunctively, we have started to use the hybrid technique, which we developed with time. It is basically our entire approach, which we've discussed until now, in conjunction with manual extraction, because a lot of patients, especially in progressed stages, have subcutaneous fibrotic nodules that are very difficult to remove with surgery. Manual extraction is a way of mobilizing these fat cells and manually being able to remove them via the incisions that have been placed. In patients with not so progressed finding stage 1, early stage 2, it can also be used to achieve a more improved aesthetic contour, because you can basically shift the fat tissue around a bit and cause a more clear definition of the tissues. Just a heads up, it's looking quite graphic. You can see the fat nodules that have been loosened and are evacuated via the incisions. The fat nodules can be quite large, and sometimes it's very difficult to remove them with the cannula, and will only lead to more excessive bleeding and prolonged surgery time by a lot at the end of the day. Here you can see this patient had a large accumulation of fat on the medial aspect of her right leg. This was relatively easily removed with manual extraction. And you can see that the tissue can be modeled quite well, right? The areas adjacent to the Achilles tendon can be brought, or the Achilles tendon can be more well defined by pushing the fat away. You can see that. And this is, for example, the result in one patient. Many patients, or probably a lot of you, will ask yourself, this looks quite brutal. Does this cause any damage to the tissues? And it's a very good question. So we started going into the tissues with an endoscope to see if there is any damage inside. And what you see, this is before manual extraction, but after liposuction. So there's still quite some fat left. When going through it after manual extraction, you can see that the vasculature stays intact. Here we can see the pinch test. As you can see, it is very easy to pinch a small portion of skin. And it allows us to check for symmetry between both legs. Then, very essential, the compression garments are put on the operating table while the patient is still asleep. The idea behind it and why compression is so important is because you have to imagine the entire space, the entire area that has been treated with liposuction is a large wound surface. The wound surface is not visible from the outside because you only see the incisions, but the entire inside is basically a large wound, and the body prefers filling up wounds with fluids. So the compression garment will press all the layers against each other to prevent fluid accumulation and prevent seroma formation. That's why it's so essential to have a good fitting compression. We always recommend custom-made compression garments, because what's so important is that lipedema is characterized by a disproportion. So no off-the-shelf compression will provide the optimal compression that each specific area needs. You need to be measured in order to achieve the best post-operative result and achieve the smoothest recovery. It is important for the garments to fit well, to sit well. The sutures have to be inside the folds, otherwise there will be a double bubble that will form in the area of the inguinal region. In patients who receive the hybrid approach, additional short stretch bandaging is performed to further compress the tissues. Post-operatively, it's very important to have lymphatic drainage, and we start that on the post-operative day. Our physiotherapists come by every day to perform lymphatic drainages on our patients. It is important to have lymphatic drainage for 6 weeks. It doesn't have to be every day. Once you're back home, it makes sense to have it 2 to 3 times a week in order to support the patient's own lymphatic system. The wearing of flat-knit class 2 compression garments is essential. It's, apart from the surgery, the most important thing. And it has to be worn for 24/7 for the first 6 weeks. After that, it can slowly be reduced, right? But the first 6 weeks are very essential. We definitely recommend early mobilization, right? Every surgery increases thrombosis risk, and the earlier patients walk up and get around, the lower the risk of thrombosis and the better. We have a park where patients can go outside, and of course now it's quite cold, but in general it's a good idea to go and get some fresh air. And patients will receive heparin injections to prevent thromboses until they're fully mobile. This is an example of an MLD treatment at our hospital. The colleagues will come by daily, perform the MLD, and then help the patients get up and walk around, because it is always a good idea to not get up on your own for the first time, because sometimes patients will feel some dizziness, the blood pressure can drop a bit, and it's always better to be accompanied. So always call a nurse or wait for the physiotherapist to help you get around. It is important to maintain proper hygiene after the surgery. So it is definitely possible to start showering the day after surgery, just with clear water, running water. So just water running over the body is perfectly fine. No bathtub, please. The wound should not be submerged underwater for a longer time, but just running water under the shower is no problem. We also recommend topical creams like arnica or heparin ointments to help with the bruising. And the sutures don't necessarily have to be removed, because they are resorbable and will dissolve with time. I know sometimes it takes a bit longer for them to dissolve, and if they start to bother you after a week, they can be removed, but there's not necessarily the need for it. The next surgery is then planned as part of the multi-step therapy concept after usually 12 weeks or 3 months. That's usually the time needed for everything to go back to baseline. So the hemoglobin levels to reach the upper reference range again, the post-operative swelling to go away again, and the patient, of course, always needs to be mentally ready for having another surgery. It is important to make dietary adjustments if those have not been done prior to surgery, right? You have to try and prevent the rebound. And of course, the body has now, after surgery, lost a certain portion of its fat cells. So everything will only spread among the remaining tissue. So sports, movement, exercises, everything that happens in water is perfect. It helps and supports the lymphatic system. Zumba, dancing, whatever you like at the end of the day. Coming to the not so nice things, and those are the complications of the surgery. Every invasive procedure has potential complications. And the most common complication with large volume liposuction is a moderate hemoglobin drop. The more progressed the case is, usually, the more tissue is removed, usually, the higher the drop in hemoglobin. And that is something that is partially expected, but has to be monitored. And that's the reason why we keep patients for a longer period of time with us. Superficial thrombophlebitis, infection, seroma is something that can emerge. Most commonly, if the compression garments are not optimal, but really with the large surface area of wound surface, it is something that may emerge. In rare, very rare cases, there may be wound healing disorders and deep venous thrombosis with the risk of pulmonary embolism. That is very, very, very rare. And these are some examples of complications. You can see hematoma formation on the left, and bruising. On the right, you can see a small skin necrosis on the calf region. This is a patient who was treated externally and has developed a sepsis and was admitted to our hospital for further treatment, and she ended up needing a skin graft to close the wounds. These are very rare cases, and it is important that if a post-operative infection is suspected, to be able to intervene quickly. Coming to the nicer things, the results. And here's just a few examples of results from different stages. This is stage 1. Stage 2 patients. And stage 3. As we touched upon, there may be excessive skin after these surgeries. In some patients, the skin will retract sufficiently. In some patients, it won't. And then it makes sense to think about skin removal surgeries. And here, for example, we have a patient who has decided to have a skin removal surgery. This is an example of a total body lift, which consists of a buttocks lift and a tummy tuck. So we have to talk about specifically our international patients. What is important? If possible, it is good to have a confirmed lipedema diagnosis. if that is, and I know it may be difficult to achieve, if it's not possible, then we can confirm the diagnosis with you. We offer video consultations where we can confirm the diagnosis, we can indicate or provide the indication for surgery. Then, as we touched upon, usually a 7-day inpatient stay is planned, and we have guest rooms available above the ward for anyone that wants to accompany you on your journey. You can bring your partner, friends, anyone to support you, and help you walk around, mobilize you, and help you with the travel. You'll have daily manual lymphatic drainage in the hospital. We have a specialized nutritionist on site to advise on dietary changes after surgery, and a cooking course where patients have the possibility to get to know each other and cook together. And what we always recommend is booking a flexible flight ticket and airport assistance to avoid any inconvenience. In some cases, the stay has to be prolonged. In those cases, it is easier if you have a flexible flight ticket that can be changed last minute. And airport assistance, many patients will think they won't need it. It's definitely recommendable. It takes a lot of the stress out of the journey. What we always recommend, if you have the possibility, to stay a few days extra in Germany if you can, so we can look after you. You can, after your 7-day stay, you can go to Potsdam and stay in a hotel there, and we'll be able to look after you in regular intervals before you fly back. We have published a 10-year retrospective study regarding the long-term outcome of multi-stage large volume liposuction. And what the data relatively clearly shows is that it makes sense to treat patients earlier rather than later, right? The outcomes in general are better the earlier the treatment starts. What are the take-home messages of this presentation? What we see and observe is that lipedema often coexists with several comorbidities, be it hypothyroidism, be it Ehlers-Danlos syndrome, be it mast cell activation syndrome, be it depression, be it obesity. There is a multifold of typically associated comorbidities. I think probably the most important point to take home from this is that liposuction has no curative intent. This may sound scary, but liposuction will give long-term substantial symptom reduction. However, since we don't know the reason how lipedema develops or what causes lipedema, you can't expect it to be curative in nature, because we have to have a causal treatment to be able to cure lipedema. Therefore, it's very important for patients to have self-treatment, self-management, psychological support, sports, exercise, dietary adjustments, and stress management is very important. We see it that in a way that we think large volume liposuctions are necessary for effective treatment. And since we expect lipedema to be, or lipedema tissue to be pathological tissue, we don't use it for fat transfer. What we do see is that liposuction can cause or can reduce the lipedema associated symptoms substantially, and also the need for conservative treatment measures, so compression garments. The success of the therapy is dependent on the BMI, stage, age, and comorbidity profile. And I think as a general rule of thumb, one can say the earlier, the better. We had the pleasure of planning and hosting the first Lipedema World Congress in Potsdam in 2023, with Dr. Ghods as the Congress President and Dr. Karen Herbst and Dr. Sandro Michelini as co-presidents. It was a great success. Over 500 attendees from all over the world came and took part in a scientific exchange where everyone tries to improve the care for lipedema patients. And it is our pleasure to spread awareness for the next Lipedema World Congress in Rome this November. It will be hosted by Dr. Michelini with Dr. Ghods and Dr. Karen Herbst as co-presidents. So I thank you for your attention. And Emma, we can...
That was so great. That was so great. You covered so many questions and people are filling the comments with, they're asking the question and then you're answering the question. This was fantastic. What a great presentation. And I really love the addition of the videos. It really adds, it's one thing to hear you talk about it, but it's another to actually be able to visualize it as you're doing. So that's fantastic. Thank you for presenting that. So I want to acknowledge, just because when we got started, I was in a bit of a hurry. So some of the directors of Lipedema Canada are very familiar with this team of doctors. We do at Lipedema Canada strive to be transparent, and we wanted you to know that some of our board members have in fact had previous surgeries with Dr. Ghods and this team. Of course, always paid independently by ourselves as patients and completely separate and independent from Lipedema Canada. And as we mentioned, there are no incentives for our organization or association. We're not promoting any one particular doctor or method. We are looking always for other opportunities to bring knowledge from all different types of clinicians. And if there are clinicians out there watching and would like to have an opportunity to present as well to help the lipedema community, always with that in mind, of course, we welcome that. And so people can reach out to us at info@lipedemacanada.com and send us an email. You guys, this was fantastic. And I understand that you might actually have a Canadian with you who you were going to do a little chatting with. You guys are in Bad Belzig, Germany. So for those who don't know location-wise, here in Canada, we measure everything in time and like distance. So it's not kilometers. We say it's about 2 hours south of Berlin at a hospital. Yeah, that specializes. You guys have made an entire practice at this hospital of treating lipedema with a dedicated unit and a complete inpatient stay with an entire team, as evidenced by some of you sitting in front. So you have a patient who is, I'm just looking over. Grace, can you give me a thumbs up if you're feeling well enough to join us? All right, you can go ahead and take yourself off of mute. Why don't we bring Grace in and you can ask her whatever questions you had planned.
Wonderful.
Hi,
Grace.
Hello, Dr. Giw. Hello, Dr. Amir, Dr. Ghods, and your assistant. Hello.
How are you?
I'm doing wonderful. Very good. Thank you. I feel fabulous.
That's wonderful to hear.
Yes.
Can you tell everyone what your journey was and where you are at the moment and what you've been through in these last 48 hours?
Okay, well, my journey has been a long and exhaustive one. I'm grateful to Emma as well. I should say thank you to her for directing me to Dr. Ghods and the team in Germany. Very grateful, as I did undergo 3 previous lipedema liposuctions in the US. They were of a low volume and the complications that go there. However, I have undergone as well in the last 10 years the bariatric gastric sleeve surgery in my journey, as I was misdiagnosed as obese. However, I had never been a big eater, and now I have a 10% stomach compared to a normal person. So that was in the journey of discovering that I'm actually diagnosed with lipedema, which unfortunately in Canada I discovered that they don't even teach it. I was told by vascular surgeons it's not even taught in the medical schools, which is very, very upsetting. I spoke with our health provincial minister. I'm from Calgary, Alberta, Canada, and as well presented all documentation that I showed them, met them in person, and still to no avail to have funding for out-of-country health expenses and whatnot. So I am looking to challenge the government on that, as this is a real pervasive condition that is life-threatening for some. And I'm sure you can speak to that, because the mobility factor for myself was extremely limiting. I went from being very active, my lipedema came on as a result of serious trauma of being hit at 200 kilometers an hour head-on drunk driving collision, and then my body, just to compensate and protect itself, I went into lipedema and put on actually 75 pounds in the first year. And I had no understanding for this. It was not attributable to food or lack of mobility, but it subsequently did deplete me in that way, and I was extremely limited. I went from training for a triathlon while in law school to almost not being able to walk from the home to the car without getting winded. So maybe some of you can identify with that, but I want to encourage you to pursue all avenues and preparation, as Dr. Giw has alluded so carefully and methodically to preparing for lipedema liposuction, which means if you can't walk within a mall, do use the aid of a shopping cart. Don't be embarrassed. Hang on to it for balance. Take your time, stop and periodically take a break and keep going. If you're able to swim, do swim. I know society puts a great stigma on the look of a woman. That's worldwide. It's just how our media and social media is. However, and I will speak from my personal experience, I almost, without bringing tears now, but I almost did not want to leave the home at all because the look, because I went I didn't go gradually stage 1, stage 2, stage 3, stage 4. I went almost from 0 to stage 4 or stage 10, if that's even possible. However, that's just being silly, but so it did make me very self-conscious. I did not lapse into depression, thank the Lord for that. But it was something where it made me very hypersensitive to looks from children, from adults, and people questioning. But I support myself. My mother's a great caregiver for me and those around me. And my mother was instrumental in encouraging me, and I encourage you all to, you must maintain muscle mass. You must maintain composure and balance and walk with your head held high, your back straight, tuck in your stomach. All these factors will help in maintaining the healthy tissue and muscle that's needed for getting through any lipedema surgery. You cannot just sit at home and not move.
Yeah.
And so, and watching your food, of course, and exercising is all a combination. It's not just one or the other. They are in tandem together. And having an anti-inflammatory diet, gluten-free, these are things that may be a little more cost prohibitive for some, but I encourage you to look into it. You will feel better. You will start to look better, even if it's, let's say, 1 pound a month. 2 pounds, it may be more, it may not be, but it's not always about the scale, because we know lipedema grows mitotically, divides on its own. And I did undergo the bariatric. I did undergo almost every single diet possible, including trying Ozempic and getting off that because of the side effects. However, I also went on a strict protein only and water diet for 2 weeks prior to my first US lipedema surgery. And I still put on 6 pounds, which was very upsetting. But that was pre my understanding of what lipedema is and what it does and how it grows in the body. So don't be discouraged, don't be dissuaded. Don't go into starvation diets and malnutrition. You must maintain good vitamin levels, as they spoke to, of the B12 levels, D3 for calcium and bone function. I also take vitamin C and zinc and biotin, and I try to maintain those levels as best as I can, and eating as much natural fruits and fibers and vegetables, and cutting out, I tell you, I'm not even going to say limit, I just say cut out the KFC, pizzas, all those high fat content foods that are easy in our North American society, and maybe in the rest of the world to get to, because those all add to the normal so-called fat of our body, which also then affects the lipedema fat in the long run. And it just compounds the issues, because then you can't tell what's the difference. What am I gaining? So I encourage you less salad dressings. I encourage you less deep fried foods. If you can bake the foods, bake it. No high fat breads. But I will quickly jump, without taking too much of your time, to the last 48 hours, which has been phenomenal. I did arrive in Germany. We left Canada on last Saturday, and the hospital did kindly arrange for a wonderful taxi service. They will do that for you. And we did arrive safely in Bad Belzig at the hospital. Accommodation was ready, and everything was organized, and they do prepare you ahead of time. They are very diligent. You must appreciate they are very busy, and they may not respond within, we expect 20 minutes of an email being sent, but they do get a turnaround of 12 hours or less. In my case, 24 max. And they are very thorough. Their English is very easy to comprehend, and there's no need to worry about, do I need German English translations or Google Translate? As you can see, Dr. Giw, the whole team, they present very well and understand what we need. They are very compassionate, very empathetic, and it has been a life-changing event for me and my mom, where now I can get back into movement. And I apologize, it's a very emotional time, and I know it will be for all of you, but do pursue the avenue. Challenge your doctors to do the proper blood work on time 4 weeks prior to surgery, as they need. Do what they need. Do your pulmonary function test if you need. And I also had my surgery on Wednesday, and it went very smooth. The anesthesiologists were phenomenal. They're very caring. They all speak English. And those that don't, have someone there right beside you to help you, guide you along the way. They even have a dimmer effect in the room, if you, just to keep you calm. Everything is very high tech, I will tell you. There's none of this pulling you off a bed. They have a sliding belt that gets you from your bed in the patient room onto the stretcher of the surgical bed, table, that is, and they're already there waiting. They have great attitudes. The team I want to also commend is the nursing staff and the assistants and the MLD staff. They are incredible, as I'm sure Emma will speak to as well. They do care. They run for you. They don't just dilly-dally walk. It's not a paycheck for them. They personally give of themselves, and you will feel that. This team here with Dr. Ghods has been carefully manicured. I can tell they've been handpicked and trained very well to identify, maybe not exactly what you're going through, but they have a special love for the patient, and they're very humble, very caring. And I've never seen one without a smile. They provide water for you, whether you like the bubbly water, carbonated, which I do, and I really appreciate having it. And they have the
thank you.
regular natural water. They provide coffee, tea, And I want to
Great.
add quickly,
Great.
the food is phenomenal. Dr. Ghods has personally attended to the fact to have, as far as I know, he may have more, but at the time last year I had my first surgery, they have and still do have 2 Michelin star chefs on staff that prepare hot meals for you. Don't listen to anything about the food being this or that. I personally am a picky eater, but it's been very, delectable dishes. And I have to speak, the other day we had actual stewed, like
Grace.
roast beef with scalloped potatoes and French green beans with a beautiful
That's
tomato sauce.
Grace.
I'm telling you,
You're making-
it's very impressive.
You're making
very
us hungry,
impressive.
Grace. You're making us hungry.
I'm sorry. I am hungry myself now.
Thank you so much. You don't.
But
Thank
I
you for
also want
the.
to, yeah.
Thank you so much. Thank you so much for your lovely words. It really means a lot. It really means a lot.
Oh, you deserve it and more. You are not just
Thank
an
you.
organization that provides this service. You are world class, and I have had the Canadian experience. I've had the US experience, and the what you provide for your patients is care. And I should stress to the viewers that the safety factor is of the highest and utmost of importance to each of you, and you do not release the patient if they are not of a good hemoglobin level. You will provide an iron infusion if necessary.
Absolutely.
You do regular
Absolutely.
blood work immediately upon surgery completion. So these are all things that help me and my family, especially my mom, to choose you to come again. And I am ready, and the planning for my next surgeries. I've lost now a total of I think it's 26 liters, and I have more to go, and I'm very excited to see the results and to maintain what I
As
have
are
to
we.
do. Yeah. And I do
Thank you so
thank you
much,
all
Grace.
and love you all.
Thank you so much. It really means the world to all of us.
Bye.
We'll let you get
Thank
some
you so
rest,
much.
Grace. Thank you so much for joining us over here. And speedy
Thank you, Emma,
recovery
as well.
and a safe journey
Thank,
home. Okay.
thank you.
Thank you,
Thank you.
Grace.
Bye.
Bye-bye.
That's some very high praise, my friends. Very high praise.
That's an honor, really.
Yeah.
Thank you.
Well, it makes lots of sense. You know, a lot of us as patients, when we're trying to figure out our way through lipedema, which includes, as you mentioned, just even trying to figure out how to get diagnosed in Canada. And if you know that you need treatment and you've had the opportunity to speak with a team like yours or any of the other qualified surgeons around the world, the next challenge can be not just figuring out how am I going to go to a foreign country, but all of the fears that come along with going to receive healthcare so far from home. And we do talk with our patients often about the experience emotionally of coming for these surgeries. These surgeries, as I know that all of you clinicians are aware, are so much more than the physical that we're experiencing. I know for myself as a patient, I received very tender care emotionally, actually from you, Dr. Giw. It was at the end of my first surgery with you, where I had been powerfully just enduring and refusing to acknowledge to anyone that I might need help or feel scared or vulnerable. I had traveled for that surgery by myself, which was the first time I had done that, and I found being alone was really scary, not because I wasn't well cared for, but because I was just scared and homesick being alone. Yeah.
Just a big step traveling around half the world and putting your health into the hands of someone else.
Yeah.
So
there's a lot of trust that goes with this team. And when we talk to patients about who are you going to choose for a surgeon, that is a very broad question that has many answers. And for some patients, they have involved multiple different surgical teams throughout the times. But you know, we'll get to the questions from our audience, but I think that the overarching message we would send to anyone considering what's the right avenue for me if I'm thinking lipedema surgery, it would be, it's not just about the technique. It's not just about the location. It's not about the price, Please do not ever look, it's not the bulk barn. We don't look for discount surgery. Okay, guys, that's dangerous. Please don't do that. But more importantly, think about the aftercare. Think about the whole scope of it's more than just who can operate on me. It's who's going to provide MLD. Am I going to have doctors and nursing staff around me in those critical, at least first 48 hours? Will I be in a hospital or will I be in a hotel room? Those are the kinds of things that, we really want to encourage, especially Canadians who are traveling uninsured and around the world, to make sure that they're thinking of when they're choosing their teams. So, obviously, you guys have got this figured out. You built a whole system around this for all of us, and we are incredibly grateful. Are you ready to do some questions? Amir, I know that it's a long day for you. It's dark in Germany. It's nearing bedtime for you guys. All right.
Brilliant.
Let's
We're
go to
ready.
our Q&A. So I'm going to dive over here and hopefully it's going to work the way I want it to. Okay, let's get into our questions. Now, some of these may have already been answered, so we can move through them rather quickly, and we've got about 15 minutes to get through all of the questions. Okay, so somebody did ask this one, and it was answered a little bit. I'm just going to make this a little bit bigger. Can you see that at all? And if not, I'm going to read it. Carla asked, is there a process that I need to do before I get surgery? Example, the length of time that I should be in compression or losing weight.
Okay, that's a good question. Generally speaking, it's not a bad idea to try some conservative treatment measures, just to see if they do anything for you. What is, I think, important to know is the fact that compression therapy will not reduce what is there already. It will help you modulate the pain, but I don't think it will necessarily help to reduce what is there. There is no requirement in terms of a duration of compression therapy. There is no requirement really to do any kind of program prior to having surgery.
Okay.
What is important is to be informed about the surgery and to know what is going to be done and to have realistic expectations of what is going to be done and how the journey is going to be at the end.
Yeah. So yeah, in your presentation, you guys had talked about not going on crash diets or doing anything to really do anything dramatic to try to impact weight, because as we know, for many of us, weight, it doesn't move when we make those kinds of adjustments. And all we might do is make ourselves nutritionally deficient ahead of surgery, which would be bad, right? KT asks us, I'm trying to make these larger, guys. I really am working on making, there's the font. Sorry about that. This is me struggling to make that larger. She asks, is there an age at which surgeons wouldn't do the surgery anymore because the patient is, quote, deemed too old? Dr. Gods.
Nobody know. My old patient was 84 years.
84. Your oldest patient
Yes.
was 84 years old.
For lipedema operation,
Wow. So
yes, you'd be surprised. Sometimes those patients are the ones that get up the quickest after surgery because they're tough.
Wow. 84. Okay, so for all of you who are saying, well, I'm 65 and my time has passed and I missed my diagnosis and I cannot possibly get surgery, 84 was the oldest patient so far. So this question was also asked in the broadcast, but we'll go ahead with that. Are there any BMIs that would be considered too high for surgeons to consider surgery, or is it stage dependent?
There is no real defined cutoff BMI because every case is different, right? If it is something that should be discussed in a consultation together to see what the best individual approach would be. There are patients where it makes sense, if they have obesity as well, to have a bariatric surgery. Liposuction is not the answer for everything.
Yeah.
it doesn't mean that because you have obesity, you don't have lipedema. You can have both. And it is important to know in which order to treat them. And oftentimes we will recommend, for example, if it's really indicated, to have bariatric surgery prior, because more or less patients will lose a large amount of weight from bariatric surgery. What we do see though is that the lipedema tissue remains. So that would allow you as a surgeon to treat the lipedema tissue more selectively at the end. So that's usually the best approach, because if you have obesity as a concomitant comorbidity, that does increase perioperative risk, and that is something that patients need to be aware of. There's no shame in it, right? It's just important to know and to have it treated.
Okay. That's an important one, and sometimes very hard for us to sort out, especially as our diseases progress. It can become a really muddy line between which of my fat is lipedema and which of my fat is,
Absolutely.
metabolic. So do you have a, like, in case anyone hasn't asked this question, do you have a guideline on how you would determine which of us would be ideal candidates for like bypass or weight loss intervention prior to surgery? Like, is there a metric that you use for that?
It will usually be a constellation of comorbidities typically associated with obesity.
Okay.
That would, pose potential risks for large volume liposuction. And of course, you can try to do some lifestyle changes first. It's not like you have to go and have bariatric surgery. It's trying to do whatever you can to achieve a healthy life.
That makes sense. We have some questions still here that came. Some of them, again, are going to have covered. So if anything was really well covered in the presentation, we can just go through it quick so we get to everybody. Joanne is asking, if I have had a double knee replacement, am I still a candidate for lipedema surgery?
Yes.
Okay, it's pretty straightforward. The answer is yes.
Absolutely. It is a very common thing that we see, is that patients who've been diagnosed very late in their life, that they already required knee replacements because all the pressure on the joints causes osteoarthritis.
That makes sense. I'm looking to make sure we disperse the questions around. Okay, Melody asks us, what kind of compression should be used prior to surgery, and for how long / weeks or months should it be worn ahead of the surgery date?
Usually we want patients to have flattened compression, class 2, like leggings, to be worn around 4 to 8 weeks prior to surgery. That's usually what we aim for. And then post-operatively, the same compressions, no new ones, should be worn for at least 6 weeks prior to surgery. And then the time they have to wear them will be reduced to half a day. But usually flattened class 2 with a closed crotch is what you need for surgery and prior to surgery as well.
Okay, with the closed crotch. Now, does it matter if we do open toe or closed toe? Some of us have preferences on that.
You can choose on your preference. There's no big difference in either.
Perfect.
Just important to know that the toes may turn blue.
Your toes may turn blue. But this is temporary. I want to assure anyone, because this has happened.
Yeah, absolutely.
This is not a permanent complication. Your toes may look blue after surgery, briefly. Okay, perfect. So I'm going to add in another question here. So Katie is asking, for those people who are not candidates for surgery, what would be the primary things that lipedema patients could do for effective management of lipedema? So talking about some more of our conservative measures.
Okay, so really there's only a handful of tools that prove more or less effective in managing lipedema. As we've touched upon multiple times, of course, is compression therapy and lymphatic drainages. What we always recommend is swimming or aqua aerobic, anything, any movement inside water will support the lymphatic system. Generally, physical exercise is very important. It is important to look after your mental health, to do stress management if you have a stressful life. It is important to exchange experiences with other patients, to feel supported, to know that you're not alone, and to know that there's others who share this path with you. There is smaller tools that you can use, like dry brushing, vibration plate. All of those, many patients will report them as being helpful, although there's not a lot of scientific evidence in regards to those topics, just because there's no studies being performed on those.
Okay. Thank you. And for more information on what conservative measures are available, I want to remind folks that the lipedemacanada.org has a wealth of information on this, including videos, and is really quite comprehensive for both patients and clinicians, and of course was developed with our help of our clinicians as well. So if you didn't catch all of that, please definitely check out the website. We've made a compendium of self-care options for you on the website. Okay, let's see. Carla asks another question. This is a good one. She wants to know, do I need to have a doctor's diagnosis before having surgery with you?
Preferably, yes. However, we do know that sometimes getting a diagnosis is really, really difficult, especially in countries where the medical education doesn't really address it that much.
Yeah.
The information about lipedema is rising now in the medical community, especially in rural areas. So we do accept patients without an official diagnosis. However, if these patients come to our consultation, there's always a thorough patient history, because as you know, a lot of the things which are needed to diagnose lipedema is actually listening to your story. What are the symptoms you have? When did it start? How did it start? How did it progress? And these are all little pieces we need to piece together to actually get to the final diagnosis, and which then can officially finalize when we're actually with us, where we can see you and touch the tissue. But a lot of the things are actually things that you deliver to us. And then our job is then to find the proper diagnosis for you, because there's no real testing about lipedema. There's no, you can't do a real MRI, CT scans, ultrasounds. There's no real studies with that. A lot of it is actually the patient history. So it is possible to come without a diagnosis, but then of course, all the digging will be a bit deeper to see if lipedema is the actual problem you have.
That makes sense. And it is such a challenge, especially in Canada, where currently lipedema is not taught in Canadian medical schools. And so we do really run into a disadvantage when trying to find practitioners. But we're working on that as well. We just don't have a magic solution just yet. Melody asks another question here. She was watching the surgery component and asked, how much risk is there as far as damage to other tissues during the surgery, such as muscles or tendons?
It depends on who will perform your surgery. Generally speaking, if a well-trained surgeon performs these surgeries, the risk is extremely low, right? The cannulas which are used during these surgeries are blunt. There is no real risk of puncturing structures if you handle the equipment the way it is intended to be handled. And the thing is, the tendons, the musculature, these are all structures running deeper to the subcutaneous tissue. So, and the muscles are covered by a sheath called the fascia, which is basically the skin covering the muscle, and it protects the muscle as well. So the risk of damaging any structures except for the fat is very low.
Okay, perfect. We have an interesting question. Leslie is asking, how soon after surgery could you swim in a freshwater lake?
That's a good question. It's a really common one when patients can get back to aqua aerobic, but really push for. The main the most important thing is that all wounds that you have from the incision wounds are closed. And once they're fully closed and healed, you're able to go into water again. It's different for every patient. For some patients, it's 3 weeks, sometimes it's 5 weeks. And if you especially want to go into a lake, then in our practice, usually that we would ask for some photos, maybe if you're unsure, but for the safe amount of weeks, it would be around 6 weeks for that.
Okay, that makes sense. And here in Canada, it's presently too cold to swim in the lake, but you want to make sure you're what we call waterproof before you get in the water. Nobody wants an infection. Carla asks another good question. She mentions that her MLD therapist indicated that she has lipedema in her chest and breast tissue. Is there anything that can be done for that?
Okay, this is a controversial one, let's say, because according to the scientific consensus at the moment, lipedema only affects the extremities.
Okay.
Right? We see a lot of patients, and a lot of patients will report that they have similar symptoms and issues, for example, in the area of the lower abdomen, around the back, and those patients should not be discredited in any way, right? It can be addressed in surgeries. It is important to know, though, there is no scientific studies that will back it.
Okay.
Right.
That makes sense. So we posed a question here on behalf of someone who couldn't get into the chat. So Diana May is asking, is there a chance of improving the lymphatic system after lipedema surgery for those patients who have secondary lymphedema?
It depends. It depends on the stage of lymphedema. It depends on how pronounced it is, right? There is scientific studies showing an improved uptake of technetium in lymphoscintigraphy after lipedema liposuction. So what that means is that it shows that there is some improved lymphatic function after liposuction and lipedema, probably due to decompression of the vessels. But that's not something that can be promised. And I think it's better to keep your expectations low in that regard. And if it improves, even better. But it will always depend on, is it secondary lymphedema or is it simultaneous primary lymphedema?
Right. Yeah, that makes sense. And it's a tough one because like a lot of us don't get a diagnosis till very late. And then the situations can get very confounded with lymphedema, lipedema, other comorbidities, obesity, and other things. It's as you guys know, it's a cornucopia sometimes when we come to you of complexity. So talking about when is the right time to intervene, Melody asks, where early intervention is recommended, does it make sense for a person to do the surgeries as soon as they are able or to wait until they have finished having children?
This is very good.
This is a very good question, yes. The real answer is there is no scientific data to it. We don't really know for sure what the best approach is. We've had patients who've had children after the treatment, and we've had patients who waited to become pregnant after their therapy.
We don't have research about that, but I can say about 20 years clinical experience. This is better before you have children. You have the liposuction. This is better for pain. This is better for your body.
Usually, yes. Because what we see is that areas that have been treated with liposuction will usually not show a substantial regrowth. So pregnancy is always one of the potential triggers of exacerbation or progression. And I just had a patient write me that she's delivering her baby soon, and she didn't have any regrowth in those areas.
Wow. I mean, that's significant. I mean, as you know, the times of hormonal change, whether it's pregnancy, puberty, menopause, or times of triggers of stress. I know as a patient myself, sometimes I feel very fearful about whatever the next hormonal life change is going to be, because I don't know how it's going to affect my body. And it sounds like we, the community, scientifically don't know yet either, because we don't have the research. But hopefully those answers will come. I know lipedema patients we want answers. We want to better understand this disease for sure. This is an easy question to answer. Leslie is asking, do you send a list of blood work that's needed before the surgery? Your associate there, Catherine. Did I pronounce it right? It's Catherine, yes? Yeah, so you usually send out lists to us, right? We get a big email and the list of what blood work is required comes to us in an email. We can take it to our doctors.
If you get information packages.
Yeah, the information.
The blood test will be on there as
Perfect. Okay, wonderful. Everyone wants to be well prepared. And then how soon before we get on planes do you need that blood work emailed back to you? Like when should we plan to have that back to you?
Like 2 weeks before the surgery would be great.
Okay, perfect. Thank
We
you.
would like to have a high level, hemoglobin level before you come to us, you know, this is very important.
I mean, the idea behind the blood work is also if any value would speak against you having surgery, you don't fly across half the globe to find out.
Right.
Because of course there will be blood work performed when you arrive at the hospital. It makes sense to have some blood work even earlier. So if you have any kind of deficiency, you still have enough time to substitute.
Yeah, you don't want to get on a plane and find out when you're in Germany that your blood levels weren't high enough to safely have surgery. So send the blood work in ahead of time, make sure you're safe, and then they'll double check it when you get there is what you're saying, yeah? Okay, I know you guys are tired. It is getting very, very late. So I'm going to skim through the questions real quick and see if there's ones that are especially exciting. The Canadians always ask excellent questions. Okay, this one is probably more specific to a person who should have a consult with you directly, but I'm going to put it up. Heidi asks, she is 47 years old with factor V laden and no previous miscarriage or clots. Is it possible to be safely treated? She believes that she is a stage 1.
Yes, we've treated quite a few patients with factor V Leiden.
We have research about that.
We also have research about other coagulopathies, for example, von Willebrand disease, which is more in the direction of bleeding disorder. And I mean, factor V Leiden is more on the hypercoagulable side. That is definitely possible and has been treated in our department multiple times.
Wonderful. I love that question already had an answer. I love that. Melody worries a bit about taking flights home and the risks of DVTs, so deep vein thrombosis or clots. How concerned should we be, and what are we doing to keep us safe?
Usually, what we recommend to patients, you always get a small care package when you are discharged from the hospital, which includes anti-thrombosis shots. So depending on the time of your flight and your discharge, we'll discuss with you the ideal time of the last injection before the flight. And as well to the injection you receive, you will also wear your compression, which is also against deep vein thrombosis. So far, luckily, we never had a patient who had any sort of thrombosis due to a long flight happening. And with all the measures you do take, you're perfectly prepared to have a safe flight home as well.
Okay, thank you. Leslie is asking a question related to hormone replacement during menopause. Now, we may not have time for this, but I'm going to toss it to you because maybe you have an answer.
Yeah, again, same story. There is no real research to it.
Okay.
A lot of patients that we see are on HRT and don't show signs of progression. So
We don't know.
Can't really give a recommendation, with good conscience. I would probably listen to the gynecologist.
Okay. Well, we're nearly through the questions here. This one was touched on a little bit, but Nicola wants to clarify Carla's question about there being lipedema in the chest and the breast area, or in this case, she's asking about breast and pubic area. Can those areas be treated during lipedema surgery on the extremities?
Yes.
Yes. Okay.
Usually, you will not perform liposuction on the breast. That's not a very common thing to do. You can address the pubic area. That's possible.
Okay.
That's definitely something that can be discussed in a consultation to make a good treatment plan on how to proceed.
Perfect. Leah is asking, this expense makes this feel really unreachable. And I believe she's referring to the expense of traveling internationally for surgery. She's asking, are there any resources or options to support with the accessibility? And I know
for you, Emma.
I was going to say, I put it up last because it is a question more for Lipedema Canada. Leah, you are correct. There is currently enormous barriers that exist for accessing surgery for any patient, whether it be trying to find somebody closer to home or as 7,000 kilometers away. Presently, lipedema is not recognized in the Canadian billing and medical system. It is something we are working on trying to have established. But related to the team that's sitting in front of us, there is a very important piece of research that is coming up within the next couple of months, which will help the cause all over the world. It's something called the Lip Leg Study. And Dr. Ghods and his team were some of the lead researchers on lip leg. And if I'm paraphrasing correctly, the study objective was to look at, over a 5-year period of time, look at just treating lipedema with conservative measures like compression and MLD versus treating it surgically, and looking for randomized control data, the gold standard of data, to tell us whether or not surgeries are safe and effective. Is that correct? Yeah.
Absolutely. It's a multi-center, randomized control, blinded trial. So it takes place over multiple centers in Germany, and patients do not know if they're going to be treated with liposuction or with conservative treatment measures. And the doctor that will be examining them after the intervention has or has not taken place also doesn't know if they've been treated with liposuction or only with conservative treatment measures. And that's really the highest level of evidence you can get in medicine. And we're very curious to see what the results will show. I mean, we've treated a third of those patients, so we kind of have a suspicion.
We have a suspicion. Well, if the suspicions are correct, and we won't suppose what they are here, we'll wait for the research to be published, and I'll make no suppositions publicly. But if the research shows what the lived experience of lipedema patients shows, then it is my hope as a patient and also as an advocate for this community that we will have the research that we need in order to actually have lipedema covered as an insured service by the public healthcare system in very short order. Does that mean it'll happen quickly? No. Does it mean we'll have the answer about whether it should be? Yes. So hope is always on the horizon when people dedicate their lives to trying to solve a problem like lipedema. Lots of great feedback here. People wanting to just let you know that you, in fact, are saving lives in a way that can't be conveyed in just simple words. Thank you so much for giving me my life and my mobility back and my quality of life. From Shannon Fergeron in Nova Scotia.
Thank you so much.
And Joanne says, we need a team like this in Canada. And so I wanted to give you a little tourism ad. The Canada is beautiful, not unlike Germany. And if you were feeling like maybe a vacation, but working, maybe stay a little while, we would welcome you here on our borders. Right? Like that would be perfect. I want to put up links. I'm looking for the link presently. Forgive me. I want to put up links for anyone who wants to get in touch with your team at Lipedema Insight on social media, Instagram. But if you go to this link right here, you guys have links to the website, which is also able to be translated into English, and ways that people could reach out to you if they would like to speak to you more about their own personal health situation.
Exactly. If any kind of questions have come up and you've not had a chance to address them here in the live stream, please don't hesitate to write us on any of the social media channels. I mean, the Facebook group is not led by us. It's a very valuable resource to exchange experiences with other patients who've already had treatment. Instagram is a way of being able to contact and reach us. There is also the link for a free consultation. The consultations are free of charge. And if you're interested or curious about any of the aspects of lipedema, don't hesitate or write us an email. We'll be happy to get back to you.
Thank you guys so much. Dr. Ghods, Dr. Amir, Dr. Giw, and Catherine, thank you so very much for joining us here. I wish you a good night as you guys go to sleep while the sun is still shining here in Canada. Thank you again for your work and for joining us. And we appreciate you so very much. Anytime you want to come back and have a chat with us, we would welcome you here.
Thank you so much, Emma.
Thank you
Thank
very
you for everything you do.
Wonderful.
And it was a pleasure. Thank you for having us.
Thank you. Thank you guys again. I want to thank everybody for tuning in with us here. If you have questions and you want to reach out to us, please send us an email at info@lipedemacanada.org. Don't let me confuse our own website, .org. Or visit us at lipedemacanada.org for the website. I want to give a special thanks to our guest, Grace, who is a Canadian recovering from surgery at the clinic in Bad Belzig, and to Dr. Ghods and his incredible team for their dedication to both research and lipedema patients alike. I want to thank my team at Lipedema Canada for making this possible for us. And again, my name is Emma Cloney. I'm the Vice President of Lipedema Canada, and I am just one of you. So I hope you've enjoyed the presentation, and it will be linked and live again after the stream and available on YouTube in case you didn't manage to take notes. Thank you again, and everybody, a good night.